You want me to get started?
Whenever you want.
Okay, so hello everybody. I'm really excited to welcome you to the late 2022 meeting. This is going to be an update and hopefully a lot of discussion following up on the 2018 workshop. And we organized this meeting in collaboration with NIA and NAC, and my coach here is Pete Nelson. And I really want to thank NIA and NAC. They've really provided incredible resources and teamwork. So at the NIA, Grayson and Nina and Erica, and at NAC, Hannah and Amy have just done an amazing job. But before we actually start with this meeting, I want to turn the mic to Pete, because as most of you probably have heard, we lost a dear friend, colleague, and really a true icon in the field of neuropathology and science. So I'm going to turn it over briefly to Pete Nelson.
So John Trojanowski was a standout, exceptional person as a researcher, as a neuropathologist, as a patient advocate, as an innovator, as a mentor, as a role model, and as a friend. He helped drive the science related to this meeting, but words cannot express the void that is created by his loss. So in consultation with the other meeting organizers, Dr. Schneider and Dr. Silverberg, we'd like to observe a few moments of silence, silence in the spirit of mourning, but also silence in the spirit of support and respect and love from this community for Dr. John Trojanowski and for Dr. Virginia Lee. Thank you.
Thank you, Pete. Excuse me, I'm sorry, I'm somehow going out of presenter mode, screwed me up. Just a second. Okay, can you see my slides?
Yes. Yes.
Okay, thank you. I'm just making sure because something kind of screwed up there. Okay, and again, everybody, welcome. Just a few housekeeping issues. We really want this to be an interactive meeting with a lot of discussion, but we do have scheduled times for discussion. So at the end of this first part of the meeting, Dennis and Dirk will be over hosting the questions and taking the questions. So as you hear the first group of talks, please write your questions in the question answer. So they just have one place to look. If you want to use the chat, you can to chat with your friends or have other conversations, but use the question answer so that we can look there to build on our discussions. The other thing I want to mention is that this is being recorded and it's going to be available on the NAC website. And finally, the poster presentations are already up on YouTube and you can go there. It's very easy. There's a link on the NIA site as well as NAC. And they're really a wonderful group of presentations, some really exciting data. And yeah, so you should definitely take a look at that. So with that, I'm going to go ahead and get started. These are my disclosures. So again, the goals of this meeting is not only to provide updates since the word late was coined, but to stimulate discussion and consider future directions and things that need to be done and questions that still abound. There's so much still to learn when it comes to TDP-43 and aging. So we're going to talk about epidemiology, clinical features, imaging features, potential or real biomarkers, genetic studies. And throughout this, I think in the back of our mind, we want to think about what does this mean for the intersection with FTLD, TDP, and the common co-occurrence of late NC and ADNC. So let's start at the beginning, and I'll just be brief to go through so we can get to the other talks, but this really began in 2006. In the neuropathology world, we knew that there was a type of frontal temporal lobar degeneration that had ubiquitin positive inclusions, but we didn't know what the main component of those inclusions were. And in 2006, we have two seminal manuscripts that find that TDP-43 is the main protein in these ubiquitin positive frontal temporal lobar degeneration cases, the other one being tau. And luckily, we have Manuel Newman here today, so you'll hear a little bit from her. But this is really where it began for TDP-43. This was 2006. We originally thought for a very brief period of time that these inclusions were specific for frontal temporal lobar degeneration. But lo and behold, Dennis Dixon and his team quickly found out that TDP-43 is actually very common in Alzheimer's disease and another disease called hippocampal sclerosis. And I'll get back to what this means in Alzheimer's disease and hippocampal sclerosis in just a minute. But I want to go back to hippocampal sclerosis because I think we toss around the term in neuropathology, and a lot of our colleagues in Alzheimer's disease research and neurodegenerative research don't know always what we're talking about. And what hippocampal sclerosis is severe, very severe neuronal loss and gliosis, typically in CA1 in the subiculum of the hippocampus. So we have very few neurons left, a lot of gliosis, the hippocampus shrinks. But this is not a specific pathology for a specific disease in general. We know that we see something like this in epilepsy, where we call it mesial temporal sclerosis. Looks a little bit different. We won't get into that today. We know that we can see it when there's global hypoxic ischemic injury to the brain, because CA1 subiculum, they're quite vulnerable to hypoxic ischemic and other injuries. But we've also known for quite a while that you can see these in neurodegenerative diseases and in aging. And I'm just highlighting a few manuscripts that came out well before TDP-43 was even noted. And you can see here we have Howard Crystal, we have Dennis Dixon, we have Sue Mira with Marla Gearing, we have Juan Troncoso, we have we just have a group of, and Jim Leverance here. We have a group of people who started seeing these pathologic markers of hippocampal sclerosis in aging and in the elderly. And they started seeing it in association what looked like an amnestic dementia, or people diagnosed with clinical Alzheimer's disease. So this was on our radar before TDP-43 was. Again, we knew it was a pathology that we occasionally saw, but there was increasing interest in how common this was in the aging population. And we knew that it was related to neurodegenerative disease because we also had seen it in frontal temporal lobar degenerations. So hippocampal sclerosis didn't come out of the blue. It was actually there was a lot of interest in this in the intersection with people diagnosed with Alzheimer's disease and other neurodegenerative disorders. So I made this picture. I haven't decided if I like it yet, of the intersection of all these things. And you can write in your comments or chat if you don't like it. But here I made a little circle for what frontal temporal lobar degeneration looks like. Around half of the cases have TDP-43. Very quickly after we saw that, or it was noted, we found that TDP-43 is actually a huge area of neurodegeneration that encompasses a lot of different diseases. And I'll just name two here again. One being Alzheimer's disease. And you can see here, it's in Depending on where you look for TDP, it could be in like half or more of Alzheimer's disease patients. And then here's hippocampal sclerosis. So you can see the vast majority of hippocampal sclerosis has TDP43, and a lot of those also have Alzheimer's disease, but not all. So we have AD TDP, we have AD TDP, HS, all very common and under-recognized. And this was the reason that we thought it was so important to let the general community know, in the scientific community, the clinical committee, really recognize that there's something else going on in brains of people with Alzheimer's disease. I put these stars out because this is where it becomes a little bit confusing, right? Because here we're outside Alzheimer's disease and people have TDP43, they may or may not have hippocampal sclerosis, and they don't have typical frontal temporal lobe degeneration. They don't have severe neuronal loss and gliosis in their frontal temporal lobes. They don't have behavioral language onset of their disease. No, they have an amnestic disorder that's age-related. But I think this is where the intersection has become somewhat confusing because there's also overlaps, which we can discuss later, and I think will be discussed today. But currently, because it's an amnestic disorder, and I think a lot of our views, it makes more sense to keep it under this late category, whereas with frontal temporal lobe degeneration, it really is a different syndrome typically. And one could argue on nomenclature, but there's certainly overlap, and there's genetic overlap. And we'll see today with some of the imaging studies and other studies that there's anatomic selective vulnerability overlap with the frontal and temporal lobes. So certainly this is an area of incredible interest still among all of us. So a couple things I wanted to point out before I turn it over to our other speakers is a couple papers we did. The first one is on the left by Brian James and colleagues, where we looked across Alzheimer's disease. And you can see here, the main point I want to make is TDP is not an epiphenomenon of high AD pathology. We actually see TDP43 pathology in around 20 to 25% of people with no Alzheimer's disease or low AD Reagan. And this is from the Ross MAP study. You can see for intermediate, we're up to almost 40%. And then with high, yes, it goes up even further to around 60%. But what we show in this paper is that if you have TDP alone, you still have an increased risk of being diagnosed with Alzheimer's dementia. If you have AD alone, of course, you have a risk of being diagnosed with Alzheimer's dementia. If you have both, your odds go way up. And then in another study we did, we showed that if you look at people with late NC, AD pathology alone, or AD with late, their trajectory of decline is much faster. And this is an article by Alifia Kapasi, who works at Rush Alzheimer's Center with me. This is Ross and MAP. And you can see here that people who have both of these pathologies are declining much faster than the people who have just AD or the people who have just late alone. And then how about this group that, before I say about the group without AD or FTLD, I'm just showing here controlling for AD and FTLD, we see the same increase in the trajectory of decline. And this was a paper by Bob Wilson from our group. And what was interesting here is the magnitude of the effect size in these models was similar as to tangles, which was an amazing finding, meaning this was not a small effect. This was really, really affecting episodic memory. And you can see here in this early study, I think we had less than 100 people, it had a very strong relationship with episodic memory, a little bit with working, but really mostly memory. But we did look at people without Alzheimer's disease or frontal temporal lobe degeneration to see, is it impinging on memory? And here again, this is with Dr. Sukriti Nag and our group of the Rush Alzheimer's Disease Center again. And in looking at people who died with low or no Alzheimer's disease neuropathologic changes, those who had TDP-43 had a markedly increased odds of having cognitive decline as well as loss of episodic memory. And in this study, we also showed language also affected, which will be interesting as you hear some other talks this morning. Interestingly, mild AD pathology in this cohort was not having an effect, but you can see here macroinfarcts, Lewy bodies, hippocampal sclerosis, we actually modeled separately, are all having effects here with episodic memory. So clinically, late, with and without a path diagnosis of Alzheimer's disease, in aging, it has a prominent amnestic syndrome. And this has been shown across studies now. And we don't think it has a significant behavioral phenotype, though I think the word here is still out a little bit in that, these are Alzheimer's centers, and a lot of, I think there's still a lot of work to be done. There's a lot of different behaviors to be looked at, but it doesn't certainly look like your typical frontal temporal lobar degeneration. Pathologically, similarly, there's really a lack of severe frontal temporal atrophy. We went back to our cases with TDP-43 that had dementia. They did not have frontal temporal atrophy. They did not have severe neuronal loss and gliosis in their frontal temporal lobes. They did not have severe spongiform encephalopathy. So it certainly doesn't look the same as frontal temporal lobar degeneration. And then, of course, the age difference. This is very much an age-related phenomenon. We'll see more of that today. It's very common. And this is really why we thought that this panel to discuss TDP-43 and aging was so very important, and not because it wasn't being studied in pathology, but because it wasn't being studied clinically and scientifically as much as we really thought it should be. And we really thought we needed increased awareness to say what's going on with TDP-43 and why are the people with TDP-43 having this amnestic syndrome and getting so much worse. But having said that, we acknowledge that it was originally found in frontal temporal lobar degeneration, and that nomenclature is very tricky in neurodegenerative diseases in general, with all of this overlap of the proteinopathies as well as vascular pathology. So today, I'm really excited for our presenters this morning, or early this afternoon. We have Ron Peterson, we have Risa Sperling, we have Patricia Boyle, Manuela Newman, as I mentioned before, and Pete Nelson. And then afterwards, we're going to have discussion led by Dennis Dixon and Dirk Keane. And then we'll have a break and have some lightning presentations of some really cool new data under pathology, genetics, epidemiology, and biomarkers. So we're really looking forward to this. And we really want a lot of discussion. So put your questions in the question answer. We apologize that we can't put you on screen, but there's over 500 people who registered for this meeting. So it would have gotten very difficult. But we will try to take all questions. This will be recorded. And so just have fun and ask your questions and don't be shy. And with that, I am going to close and introduce Ron Peterson, who doesn't really need an introduction, for his work, his thoughts on the clinical intersection. Thank you.
Well, thanks very much, Julie. I appreciate the opportunity to participate in this symposium. Both you and Pete have done a lion's share of work putting this together, and I know what the background it takes to do this. So also like to thank Nina and Grayson, Erica for putting this all together, and for Erica holding my hand during the presentations like usual. So what Pete and Julie asked me to do was just come at this from a clinical perspective in terms of patients not uncommonly, as they're aging, come into the doctor with the question of, I'm not remembering as well as I used to, what's going on? So with that as a backdrop, then I thought I would just put out a couple of cases that might illustrate this. Here are my disclosures. I don't think they're too relevant for today's discussions, although it will relate to how we select people for clinical trials that Risa will get into. So as I was saying, amnestic presentations are very common in aging. Now, there are atypical presentations of these cognitive disorders. There's visual variance, language disorders, dysexecutive behavioral, but by and large, it's an amnestic presentation that is most common, particularly in individuals in their 70s or 80s. So the first case I'd like to discuss is a 76-year-old retired physician who was forgetful for about a year, but as we all know, that's probably an underestimate of the actual duration of the forgetfulness. Tended to repeat himself. His wife certainly noticed that he was doing this more often. Some decrease in organizational skills. Formerly, he handled all the travel arrangements for the family, airlines, hotels, rental cars, and he was having more difficulty with this. He could do it, but it was a little more challenging. Other IADLs were largely preserved. His short test of mental status was 34/38, equivalent to about a 27 on the MMSE. And at this point in time, clinically, we thought he had amnestic mild cognitive impairment. Functioning pretty well, but he knew his memory was not what it used to be. We put him in the Alzheimer's Disease Research Center, followed him over several years. Over the next few years, he progressed with his forgetfulness. Other behavioral issues started to arise. Some cognitive deficits in other domains appeared. And while his neuropsychological testing profile declined, his screening mental status stayed reasonably stable. But we thought that he had probably slipped into the dementia range, realizing, of course, that this is arbitrary. He continued to progress as we followed him. Along the way, we did a research LP on him, and the data came back very suggestive of an Alzheimer's disease process. Low A beta 42, elevated p tau, total tau, and the p tau A beta 42 ratio was elevated. He passed away at age 84 with complications of Alzheimer's disease after being placed in an institution. Here's his MR at age 76, global atrophy clearly, but some mesial temporal lobe atrophy. And as we look here on the radiologic left, perhaps his left hippocampal formation was a bit more atrophic than his right. Not unexpected for what this picture was. We also did an FDG PET scan, and this is the Cortex ID rendering of that with the statistical mapping showing that on the lateral views here, he has hypometabolism in the parietal and temporal regions, really bilaterally. He has it in the precuneus and in the posterior cingulate regions as well. And the other projections basically show the same thing. If we highlight now a couple of areas that were of interest here, note that he does have lateral temporal hypometabolism. But if you look in the inferior view here, he really does not have particularly striking hypometabolism there. And my screen is freezing. There we go. So here I've circled the two areas of the lateral temporal hypometabolism and the relatively spared hypometabolism in the medial temporal region. Amyloid PET scan was quite positive throughout the entire course, and it gradually increased over time. So he clearly had amyloid in his tau PET scan. Similarly, particularly in the temporal region, inferior and lateral temporal regions, he was tau positive. So for all intents and purposes, then, he really had a typical amnestic MCI progressing to an amnestic dementia with underlying Alzheimer's disease pathology. And when he came to post, in fact, this was verified. And I want to thank Melissa Murray for putting these slides together. So in the upper left there, we see that, in fact, he had amyloid plaques with dystrophic neurites in the periphery. And he also had extensive tau, some tangles, grains, and tau fibrils in the frontal lobe. He also had some alpha-synuclein in the amygdala, but he did not have any TDP. So he had an Alzheimer's disease neuropathologic change of A3, B3, C3 with coexisting amygdala-predominant Lewy bodies, but without any late. So looks like a pretty typical progression of amnestic Alzheimer's disease. The second case then, another 76-year-old person, retired secretary, forgetful, now for 8 years. So You wonder, is 8 years really mean 10 years, 12 years? Hard to tell. Tended to repeat herself, was having some difficulty reading because she had forgotten what she had just read, but her reading skills were preserved. IADLs otherwise were relatively preserved, so we thought this looked like an amnestic mild cognitive impairment as well. Put her in the ADRC, followed her for a number of years, progression in forgetfulness. Her daily activities fell off more dramatically. Her cognitive testing profile declined a bit, and she developed what we called mild to moderate dementia as a syndrome. Here was her MRI scan at age 76. So actually somewhat less global atrophy, but striking hippocampal atrophy, just mere slivers of the hippocampi there from what we had seen with the previous person with Alzheimer's disease. And here is her FDG PET scan with some hypometabolism here in the posterior cingulate area, but notably in the medial, in the inferior view here on the bottom right, we see hypometabolism in the medial temporal region. And so now if we highlight these areas, we see that there's the opposite ratio, if you will, of hypometabolism, more so in this case in the medial temporal than in the lateral temporal region. And that in fact may be very noteworthy. And our colleagues, Hugo Botha, Dave Jones have pointed out that this ratio may in fact be quite helpful to the clinician in trying to discriminate among the various causes of an amnestic presentation. Here's this person's amyloid PET scan, which is negative, and the tau PET scan is also negative. So this is a tau negative PET scan in the setting of significant hippocampal atrophy. So it's not tau that's causing the atrophy in the medial temporal lobe in this particular individual. Again, with Melissa's help, we got the pathologic specimens for this particular individual. Really no amyloid, really no tau to speak of. There were our gyrophilic grains present, but really the person had TDP in the amygdala, the hippocampus, and the frontal lobe. Neuronal cytoplasmic inclusions, perivascular Lin bodies, meaning TDP in the vasculature as well, and also an association of fine neurites. So in this case, the Alzheimer's disease neuropathologic changes were A1, B1, C0. This was a late neuropathic change, stage 3 with hippocampal sclerosis and coexisting our gyrophilic grain disease. So somewhat clinical pictures that were similar, but the underlying etiology turned out to be quite different. And again, Hugo Botha, Dave Jones have put together a group of these people which represent amnestic presentations with MCI or dementia. They always looked like they were evolving Alzheimer's disease, all had hippocampal atrophy or cortical thinning in the AD signature regions. Some were amyloid positive, some were amyloid negative, all tau PET negative. So in those who are amyloid positive, you would put it A plus, T minus, N plus. And these people then really would be included in clinical trials, because if they met the amnestic profile, they had a positive amyloid scan, you would include them. But in fact, that was not the culprit causing their underlying disorder. From Dave Jones' global functional state space, when he put this particular patient into the model and looked at what groups of individuals they tended to correlate with. On the top row, we have the axial views, again showing the blue is the area of hypometabolism. On the axial views in the middle, again, the medial temporal lobe, and on the sagittal view is the same look. So there seems to be a coalescence of appearance of FDG patterns with these individuals. So let me summarize by saying that a person comes in with a memory complaint, you do a history and exam, you may get neuropsychological testing to characterize the particular cognitive profile, you come up with a diagnosis of amnestic MCI, you do an MRI to make sure there's nothing else cooking, and the MRI sort of differentiates to a certain extent, makes you think, this might be more than just a typical Alzheimer's process. There's striking medial temporal lobe atrophy. You may do an FDG PET scan. the FDG will give you this ratio difference that appears different in the AD case versus the late case. And in fact, you put these factors together and you may be further down the road. You can do amyloid PET, you can do tau PET to see if in fact those are contributing factors as well, and to sort out the whole picture. So, etiology of amnestic MCI. MCI due to AD, amnestic history, MR, hippocampal formation atrophy, FDG, temporal parietal hypometabolism, and molecular PET scans are generally positive. MCI due to late, long amnestic history. So the clinician is wondering now, gee, this person has remained quite functional for a long period of time in the setting of an amnestic disorder. The MRI, again, prominent hippocampal formation atrophy, the slivers of the hippocampi are left. And then you look at the FDG scan and you see this reverse ratio of hypometabolism between the medial temporal lobe and the lateral temporal lobe. And the molecular PET could be plus or minus in either direction. So I think the amnestic presentations are very common. The features that are histories suggestive of the type of underlying disorder may involve duration of symptoms. MRI can be suggestive, not specific. FDG PET can be helpful in the metabolic signature as well. And the amyloid and tau PET scans help to see whether there are contributing factors there as well. But we certainly need better specificity before we enroll some of these people into clinical trials, and Risa will be dealing with that in just a moment. And I would suggest that maybe we talk about these as neuropathology components rather than you got this disease or that disease, but you have a component involving this particular pathologic entity, that particular pathologic entity. And it's really more of a collection. And many of the people on this meeting have generated the data and the literature that have substantiated that position. So here are my colleagues at Mayo who generated the data that I've discussed today, and I hope this gives some kind of a contextual view of dealing with amnestic disorders in aging. But let me stop there and turn it back to you, Julie.
Thank you, Ron. That was great. So our next speaker is Dr. Risa Sperling, who's going to be focusing on clinical trials.
Thanks so much. Let me just share my screen here. All right, hang on one sec. Make sure you can see this. All right. So first of all, thank you so much to the organizers for inviting me. I'm really hoping to learn a lot at this meeting. And here are my disclosures. And again, the most important disclosure is sadly, I am not a neuropathologist and I clearly don't know enough about TDP-43. So I'm very much hoping to learn, but I'm going to talk about late in the context of what we think, how it might be impacting our clinical trials in Alzheimer's disease. And I'm going to focus especially on these very early prevention trials. So, and you'll, I think, see some synergies to what Julie already presented, looking at autopsy and looking backwards. Now we're going to be looking at biomarkers and looking forward. So again, I am going to focus on the earliest part of the continuum of Alzheimer's disease, when people have pathology that we can detect before they have a clear clinical impairment, and refer to this, of course, as preclinical Alzheimer's disease. So I won't go through these details of the data that support this, but I'm going to show you a little bit, because I'm going to show you some of the warts in our theories about what amyloid and tau might be doing, because I think some of this really is where late TDP-43 is contributing. So again, about a third or 30% or so of people who are clinically normal show evidence of amyloid pathology in exactly the same range that we see in anatomically at later stages of MCI and AD dementia. And now there are a number of studies who followed these people who are clinically normal but have evidence of elevated amyloid. Here's data from the Harvard Aging Brain study that I co-lead with Keith Johnson. In blue are the people without elevated amyloid. amyloid at baseline. In red are those who have elevated amyloid. They and we are all blinded to this data, but you can see that they show cognitive decline over the course of about 5 years. So that's a single site study. Here's data from ADNI, and looks very similar with longer follow-up, again, blue being normal or low amyloid levels and elevated in orange. And again, you can see that after about 2 years, these individuals start to decline precipitously. And it takes 4 or 5 years before we really start to see these folks progress to impairment. So that all seems great, and we can identify these people and talk about risk, but it gets a little tough in the heterogeneity that we actually observe in these individuals. So first I'll highlight ApoE4. It's been known actually for almost 10 years now that people who have elevated amyloid decline faster if they carry 1 or 2 copies of the E4 allele. That's only really in the preclinical stage. We don't see that as much once people are clearly symptomatic with MCI or AD dementia, but in the preclinical stage, that ApoE4 really matters. And in the middle panel here, it especially matters in women with E4. And why is this relevant to the topic of today? Well, here's some beautiful work that Julie Schneider helped Han-Sik Yang and the ROS-MEP cohort, looking at whether ApoE4 has independent effects on TDP-43 in addition to its effects on AD pathology. And I think this is very relevant because we can equate people on their amyloid load, and we still see evidence that ApoE4 is increasing the likelihood of decline. That is not accounted for by tau completely. So there is an effect of ApoE4 on tau. When we look at tau PET, I'll talk about that in a moment, but there's still this effect of ApoE4 that we refer to sometimes as amyloid independent that we don't understand, but it's a pretty substantial effect in prediction of cognitive decline. So the other piece of this are, again, these other biomarkers that we can detect in individuals who are still normal. And starting again way back in 2014, we realized that amyloid alone is insufficient to predict cognitive decline. And amyloid plus neurodegenerative markers, in this case, primarily hippocampal volume, but we also can see this with FDG hypometabolism. It's the combination of amyloid and neurodegenerative markers that really tell you who is most likely to decline, particularly over in this early study, only 3 years. And then on the right, I'm showing you some newer data that comes from Ellen Grober, who looked at our Harvard Aging Brain Study data and really focused, I hope you can see this over here on the far right, because she really focused on people who showed this memory impairment and again showed that this was primarily related to hippocampal volume. Again, if you have both markers, amyloid and hippocampal volume, it is significantly more likely that you'll demonstrate decline in episodic memory. So I haven't talked much about tau yet. And of course, starting in about 2014, we had the ability to detect both amyloid and tau PET with imaging. You could detect it with spinal fluid much before that, but the ability to start to look at tau in this elevated amyloid clinically normal group, I think was particularly important because we could see this evidence that not only did most of these people have a head full of amyloid, but they also showed tau that was spreading beyond the medial temporal lobe into the cortex, and that was a very high risk for people who would have imminent cognitive decline, even though they started out normal. This is data from Keith Johnson in our HABs again, and we refer to this as the catastrophe because there seems to be this period once you get to a certain level of amyloidosis where people suddenly take off in their neocortical tau accumulation. And once that happens, shown here in red, these are people who all started out normal but progressed to a diagnosis of MCI typically within 2 years of that tau PET scan if they had both elevated amyloid and elevated tau. But I do want to point out a couple of things on this graph on the right. So one, not everybody with elevated amyloid gets this catastrophe or a lot of tau. There are a few people who didn't have as much tau who declined, and even a few people who don't have much amyloid or tau who decline. And we, of course, are trying to understand that group as well. So this all led to this idea of how do we do these preclinical AD trials. I'm going to be talking about secondary prevention. Primarily, these are people who have evidence of AD pathology, don't yet have clinical impairment, even though they may be having this transitional decline. And our job is to try to prevent them from developing a significant memory loss. So the A4 study, which I hope people might have heard about, I won't go into detail, but these are people who are in the range that late might be particularly relevant in, because they had to be 65 to 85 to come in. And this is a very long study, 4.5, actually it's closer to 5 years because of the pandemic in the middle. And we're finally getting close to the end of that study. The top line results are expected about a year from now. And in this case, we're testing an antibody against soluble A-beta, solanezumab. And then the AHEAD study, which had just started about a year ago for recruitment. And here we're actually looking even earlier in the disease in the A3 study, and intermediate, and later in people who are still asymptomatic but have very high levels of amyloid in A4-5. And this study, these two studies have a shared platform screening. This is, again, actively enrolling now at about 75 sites. And importantly, we're going down to age 55. So we're now here in the range probably before. There's a lot of TDP-43, at least based on the data shown so far, and looking very early in the amyloidosis, which I think may be important for intervention. And we're testing here an antibody that's actually both plaque clearing and going after protofibrils. So why is this important for today? So here's the model that we are operating on in these clinical trials, that we have an A-beta positive group and an A-beta negative group, and that they increasingly split over time. And I showed you that observational data that supports this. And then ideally, we'd be able to just change the amyloid and move the amyloid positive group up towards the amyloid negative group. And this is where A4 is, and then A3 and A4-5 even earlier and later. But the problem is that we increasingly know from the work that's already been presented and will be presented that these individuals who we are calling amyloid positive and are assuming that amyloid is the main driver of their decline are likely not pure AD pathology. So this is a slide that Greg Jica finally very kindly allowed me to present, and he's got a great talk, I think, in the pre-recorded that has much more detail you should look at. But PAD here is in preclinical AD, and you can see already that there's quite a bit of evidence of other pathology in the small number of autopsy they've had in a preclinical prevention trial to date. So these are the things that keep me up at night, that again, our best biomarkers and the neuropath data, although maybe this is getting better, and we'll hear that from Patricia Boyle today, but most of our models, even if we put everything, amyloid, tau, genetics, vascular disease, we really account for less than 50% of the variance in cognitive decline prior to dementia. It gets much better when you're looking at the impaired stages. And so we've really been trying to understand what are the other factors or co-pathologies that happen with amyloid that drive cognitive decline. And are we going to be able to impact these if we're only targeting amyloid? And we already know that there's a subset only of those with elevated amyloid who get a lot of tau, get these other pathologies, and we need to predict who they are because there's a lot of evidence of synergy in driving decline. We definitely see amyloid plus tau driving it. We have a bunch of papers of amyloid plus vascular disease being synergistic in driving decline, and some new data coming out that it's the amyloid and the vascular that seems to drive the tau accumulation. But if we wait and we only pick people who have a lot of amyloid, a lot of tau, potentially a lot of TDP-43, unclear to me that we're going to be able to intervene well with just an anti-amyloid therapy because there's other things going on. And relevant to today, what if that factor in a lot of older people is TDP-43 and we can't measure it? So that's a major yipes for me. So I'm going to put out some crazy philosophical ideas here, which I would love to get people's thoughts on. So increasingly, I am wondering whether what we think of as late onset sporadic AD and perhaps age-associated cognitive decline more broadly really is more broadly this failure of being able to empty the protein trash. And of course, this Greg Petzko and lots of people have postulated this, but I think our biomarker data are starting to support this as well. And we see all of these pathologies in specific anatomic distributions, at least where they start. So a lot of, again, this tau accumulating in the medial temporal lobe that has been postulated by Marcel Meslem and others to be because of synaptic plasticity needed there. But then we also have this new data I won't show you today, but really talking about the locus coeruleus and why is that so critical and so early. We see amyloid in the default network, which of course is extracellular. There's been Mark Rakel's work and others suggest maybe this is due to high metabolic demands. We can see with fMRI and other studies, these areas are going up and down as you think about external, internal stimuli. And A-beta is one of the most rapidly turned over proteins. So maybe it's just because there's a lot of it. It's cleaved in the extracellular space. And of course, we don't know what it might do in especially APP in memory or learning. And then there's TDP-43, which I'm hopefully going to learn more about today. But in reading, it's postulated it's mRNA regulation or DNA transcription. Well, why is it in the anatomic localization that we see it in late and in AD? We need to understand that. Is that also plasticity? How is it co-occurring with tau? I think we need to understand this. And again, I'm talking about older people here, but in fact, when you look in the Diane data, even autosomal dominant AD with overproduction of A-beta since birth, you really don't see these other pathologies until there's failure of these clearance mechanisms. So here's what I've been starting to wonder about for clinical trials. So can we actually go after all of these proteins by augmenting ubiquitous protein clearance mechanisms or reversing immunosenescence? Actually an MS doc at our place, Howard Weiner, is working on this with a Protalin trial, just trying to zoop up the microglial activation non-specifically to go after A-beta and tau, but perhaps it will also go after things like TDP-43. And then this is probably the most heretical idea I'm going to propose, but I want to bring it up. Is it possible that by clearing a lot of amyloid or tau, if we've got therapeutics that do that, we actually might improve the clearance of TDP-43, perhaps in its oligomeric form, if not in its crystallized form, by tipping the balance and freeing up protein clearance mechanisms by getting rid of so much A-beta, which is, again, the most common turned over protein. But we have these problems of extracellular and intracellular. Where do we want to go after? Is it in its oligomeric forms and in all of these forms? So I think we have a lot to learn there. Obviously, we would love to develop TDP-43 specific interventions. I think that would be ideal. And then we could combine them in factorial designs. So we've moved forward with trying to do this with amyloid and tau. This is a platform design that Adam Boxer and Keith Johnson have put forward, where we've got monotherapy for A-beta, monotherapy for anti-tau, and combination. And we've already started talking about why couldn't we bring in other proteinopathies, going after TDP-43 in a similar way, so that you're going after multiple proteinopathies at a time, because I think it's pretty clear from Julie and from our data that multiple hits like this are what really drive decline. So in summary, I will say that I think it's very likely that late, or at least TDP-43, is contributing to cognitive decline in preclinical AD, and perhaps even in preclinical AD, where we see just a little bit of A-beta, but we see some decline already. And that we really need to capture autopsies as in these large prevention trials, so we can really understand both in the placebo group, the contribution, but also if we actually are successful at changing amyloid, does it change not only tau, but TDP-43? We need to think about these trial designs for both preclinical and prodromal AD that are combination, because it's not just one proteinopathy, I think, in any of these. And ideally, we would treat late as an individual entity. But I think before we can do that, we need reliable biomarkers, both to identify those who have that pathology, especially if it's in isolation, but even in combination with AD pathology. And we need to be able to measure that specifically as an outcome in our trials. So I want to acknowledge the great group of people I get to work with in all of these studies, and especially the research participants and their study partners who make these data available to us. So thank you so very much.
Thank you, Risa. That was fabulous. Okay, our next speaker is Patricia Boyle, who's going to be discussing the impact of late on cognitive trajectories.
Okay, can you see my slides? Let me get this full screen. I don't know why it's not going. Oh, here we go. I'm not getting it on full screen. Sorry. Oh, there we go. Okay, can you see that full screen now?
Yes.
All right, great. I'd like to begin, of course, by thanking the organizers for inviting me today, and of course, thanking Julie, whose work is absolutely integral to everything we do here at Rush. But also, I'd like to thank the other two names you see on this slide, Tianhao Wang and Lei Yu, who are my close collaborators who did all of the heavy lifting for the work that you're going to see today. So all credit and thanks goes to them for this presentation. Today, I'm going to cover two topics. The first is the impact of late versus other neuropathologies on late life cognitive trajectories. And as Risa mentioned, one metric we use to quantify the impact of pathology on cognitive decline in old age is variance explained. This is something we've been doing over many years. I will update you on our most recent publication, as well as show some brand new results that are just in and have not yet been published. So hopefully those will be exciting for this group. Next, I will show some data on the effects of late versus Alzheimer's disease on specific cognitive domains to address the question, is there a domain-specific profile associated with late? Hopefully at the end, we'll have some time for discussion. The data I'm going to show today come from the Rush Memory and Aging Project, which you're all familiar with. Briefly, we have longitudinal cognitive data available from these participants spanning nearly 3 decades, making it really ideal data from which to estimate cognitive trajectories. We have over 1,500 autopsies done to date, and those will provide the basis for the results I'm showing today. These studies share 21 cognitive tests in common. From those, we can create composite measures of global cognition as well as specific cognitive domains. And Julie mentioned several of the neuropathologic indices. We have 11 in total that cover the neurodegenerative diseases, Alzheimer's, TDP-43, hippocampal sclerosis, and so on, as well as vascular conditions. Now, we know that late is defined as TDP with or without HS. So I will use the terms TDP and hippocampal sclerosis, or HS, to talk about those pathologies when I'm referring to them individually, but I'll use the term late when I'm describing TDP plus or minus HS. So we've done considerable work over the years looking at the contribution of different pathologies to late life cognitive decline. And this work, of course, has evolved as our understanding of the pathologic drivers of cognitive aging has evolved. So we've added new pathologies over time and added more detailed ways of looking at those pathologies. Like most other studies of cognitive aging, most of the work we've done in this space has involved linear models. So where we assume that cognitive decline follows a straight line. When we look at the contribution of pathologies separately, individually, to global cognitive decline using this type of approach, what we consistently see is that AD pathology is a main driver of late life cognitive decline. It is most strongly related to cognitive decline and accounts for around 30% of the variance. But TDP and HS are also important. In our most recent look at this, in a paper published in 2021, we found that TDP accounts for approximately 7% of the variance and decline by itself, and separately, HS accounts for around 3% of the variance and decline. And just to give you a point of comparison, any of the vascular indices, looking at them individually, accounted for less than 3%, many hovering around 1%. So these are significant determinants of cognitive decline. Now, we know that the pathologic indices are not independent of each other. They're related. So there certainly is shared variance between them. So to really understand their full contribution to cognitive aging, we need to look at them together. When we do this in a linear fashion, we found that the 11 pathologic indices together explained 43% of the variance in cognitive decline. So like Risa said, under 50%. Certainly, these pathologies are the most important drivers of cognitive decline that we know of. There is nothing else that accounts for this kind of a chunk of variance of decline. But there is variance still unaccounted for. Now, an important caveat of prior work is that we know that late life cognitive aging trajectories are not linear. In the last few years of life in particular, we tend to see a sharp acceleration in the rate of cognitive decline. And indeed, that nonlinear or terminal cognitive change accounts for the majority of the cognitive decline we see overall. By our estimation, nonlinear change accounts for around 70% of the total cognitive loss we see in old age. So it is exceedingly important to consider nonlinear decline, both to A, precisely characterize late life cognitive aging trajectories, and B, then quantify the impact of pathology on those trajectories. So today I'm going to show you some new analyses in which we used an innovative functional mixed effects model to robustly capture cognitive aging trajectories using a flexible approach. And by flexible, I mean this approach does not require a pre-specified functional form. So we relax the assumption of linearity and let the data decide how the cognitive aging trajectories look. So it's a more precise way of estimating the trajectory itself, first of all. In the analytic sample for this estimation, we have a little over 1,100 ROSMAP participants. We require at least 3 cognitive evaluations to allow for a good estimation of trajectory, complete neuropathologic data, and their mean age at death was around 90 years. And importantly, on average, participants in these analyses had about 9 years of follow-up cognitive assessments. That's a nice, dense amount of data to allow for a robust estimation of the trajectory. Of these participants, 68% met pathologic criteria for AD. And here we use a 4-stage TDP variable, and you can see how it breaks down here in the overall cohort. Nearly half of individuals are stage 0. Around 20% have TDP stage 1 in the amygdala, 11% amygdala and limbic, and then nearly a quarter extending into neocortical regions. Now, when we look at the contribution of the pathologies to variances of decline using the FME model, again, we do see that AD pathology is a major driver of decline. So when we look at these pathologic indices individually, if we take our global measure of AD pathology, you can see it's around 27% of the variance in decline, accounts for around 27% of the variance in decline. If we look at our more specific, molecularly specific measures of AD, we see that tangles are really the major thing here. They're accounting for about 40% of the variance of decline by themselves. But again, TDP and hippocampal sclerosis are important drivers. TDP accounts for about 8% by itself, and again, HS about 7% by itself. Now, again, we have this shared variance issue. So when we look at all of the pathologic indices together, we now, using the FME model, find that they account for around 50% of the variance. So this is a considerable jump from what we saw in the linear setting. And that's again, in part due to the precision that this FME model allows.
Wait,
We can also look at
I'm sorry to interrupt you, Patricia, but we can't see the bottom number there. Would you? Is there any way?
Oh no, what can I do?
Bottom line there.
Yeah, I don't know. Oh shoot.
It's just one number. Maybe you can tell us what that number
It's
is.
50%. Oh, it's 50%. It's the total contribution of all the pathologies is 50%.
Thank you.
Sorry, I don't know why you can't see that. On mine, I can see it. But I think hopefully this is the only slide that will be affected. Let me know, Pete, if there's something else. When we look at the groupings of the pathologic indices in categories for AD, depending on the order of entry of the specific markers, we find a range of variance accounted for from 30 to 40%. For TDP and HS late, we see a range of variance accounted for up to about 9%. If you compare the numbers for the individual pathologies in this table, you can see that these are the major determinants of late life cognitive decline. We have Lewy bodies coming in individually around 5%. Most of the vascular pathologies are below 1%, really with the exception of CAA. So what this is telling us is with a little bit better precision than we've been able to see in the past, both AD pathology and TDP-HS late are important drivers of decline. So we next use the FME model to look at the effects of late versus Alzheimer's AD on cognitive aging trajectories to see if there's a domain-specific profile of late. Here, late was defined as present if our TDP variable was stage 2 or 3, plus or minus HS, and absent if it was 0 or 1. Pathologic AD was defined based on Reagan criteria. Now, we use essentially the same inclusion criteria here, but we excluded individuals with Lewy bodies just for clarity for this presentation. So we have a slightly smaller sample. And all of the analyses I'll show you now controlled for vascular pathologies. As you would imagine, individuals who had late tended to have more pathology overall. I have an extra slide on this at the end if there's time later, but they had more neurodegenerative pathologies in general, and of course, more hippocampal sclerosis in particular. So those with late had around 23% of them had hippocampal sclerosis compared to only 2% of those who did not have late. So now if we use the FME model to look at the effects of late and AD on global cognition, here what you can see are the mean trajectories for TDP in red versus AD in black superimposed on the raw trajectories. And I show you this just to point out a couple of things. First, if you just look at the raw trajectories, you can see that there's tremendous heterogeneity in late life cognitive aging trajectories. They're really all over the board, but there's a clear tendency toward that nonlinear change at the end of the life. This is something that we think is essential to capture in these kinds of studies. Second, you can see that overall, the effects of late and AD on global cognition are generally pretty similar. If we blow this up a bit and we look at the mean trajectories and their confidence intervals here shown on the right, we can see that both late and AD tend to start exerting deleterious effects on cognition around 10 years prior to death, and they're associated with a progressive deterioration in function thereafter. Now, when we look at the specific cognitive domains, we see that late and AD tend to have relatively similar effects on episodic memory and semantic memory. So in the table or the figure on the left, we see that both pathologies tend to affect episodic memory around 10 years before death, and they have prominent effects on episodic memory, as we've already heard from Julie, Ron, and so on. Then on the right, we can see that they both have similar effects on semantic memory, but those effects begin considerably later, around 5 years prior to death. But again, their overall pattern of change looks similar, suggesting these two diseases are affecting these domains similarly. Now, when we look at the other cognitive domains, however, we see some differential effects. So if you look at working memory, the panel on the left, we can see that late AD tends to affect working memory considerably earlier than late. So beginning around 10 years before death, we see an effect of AD on working memory, but the effect for late is much later, closer to 5 years prior to death. And again, they're both having progressive effects, but again, the real key issue here is the timing of effects. For perceptual speed, we see that AD is starting to affect AD around 7 years before death with a progressive deterioration thereafter, whereas late is not affecting perceptual speed until considerably later, just a few years prior to death. Finally, visuospatial abilities is most different. Here we see, again, AD is affecting visuospatial abilities much earlier and more robustly, whereas late is affecting visuospatial abilities later. And you can see that those lines clearly diverge at the end. So the effect of late on visuospatial abilities is considerably less than AD, where we can still see that terminal effect. Now here, I'm just showing you the effects of late versus AD across the 5 domains in a single figure. And if you look at the figure on the left, which shows the effect of late on the 5 cognitive domains all at once, you can see that late affects episodic memory and semantic memory earliest. Those are those bottom 2 lines, or they're in the bottom 3 lines, the red line and the green line. Black is global cognition. And relatively later affects the other domains, and to a lesser degree. So those top few lines at the top of the figure there, those are the working memory, perceptual speed, and visuospatial abilities. By contrast, for AD, we again see that early predominant effect on episodic memory, but really AD is associated with progressive decline in all 5 cognitive systems. So just to summarize, late is certainly an important determinant of cognitive decline in old age, independent of other pathologies. The effects of late and AD are similar for episodic and semantic memory, but they're different for other cognitive domains. In particular, late affects working memory, perceptual speed, and visual spatial abilities years after we tend to see the effect of AD. And there's a distinctly milder effect on visuospatial abilities. Now, given that late and AD do both predominantly affect memory functions, these findings do present a challenge in terms of the feasibility of differentiating late clinical syndrome from that of AD. And I think this and other work that we've heard so far and we'll hear later today really does underscore the need for a biomarker for late. In addition to that, I think all of this suggests that investigation of other potential distinguishing features, behavioral and other, will be important, particularly with regard to efforts to differentiate these syndromes in clinical settings. And we and others are already working in this space a little bit. And if I know Pete, I'm sure another late meeting is already being planned, so maybe we can discuss that in a few more years. I'd like to just thank, of course, our participants, my collaborators, other faculty members at the Rush Alzheimer's Disease Center. Thank you all for your time.
Thank you so much, Patricia. That was great.
Thank you.
Okay, we should probably move on. Our next speaker is Dr. Manuela Newman, late NC and ALS LD-TDP, neuropathologic criteria, boundary issues, and open questions.
Just need to find to share my screen. Just let me see. Here we go. I think you should see that all. Yep, okay. So thanks for the invitation and for giving me the opportunity to share some of my thoughts on, from a point of view of a neuropathologist on the topic of late and frontotemporal lobar degeneration, ALS. So the 2 points I want to address in the next couple of minutes is really focusing on neuropathological criteria and guidelines. So what is the overlap and thoughts how we can refine the criteria, and the other last slide is to give some open questions on so what is the clinical relevance interpretation of late in NC from a clinical perspective. So let me start with briefly summarizing the clinical, the neuropathological criteria for the different TDP polyneuropathies. So when we talk about FTLD TDP, as the name already says, so it's a frontal or temporal degeneration, at least some. And then there's TDP pathology in the frontal and temporal neocortex, amygdala, hippocampus, basal ganglia, and based on the morphology and distribution patterns of inclusions, we can delineate at least 5 distinct subtypes which show a close correlation with genetic defects and clinical phenotypes. So the other primary TDP proteinopathy is ALS with TDP pathology, and for that we characteristically have a degeneration of both first and second motor neuron, and this is associated with TDP pathology in the spinal cord and primary motor cortex. And optionally, as shown by the work by Brett Schneider and many others, other regions like frontal striatum or hippocampus can be affected in later stages. For late, the neuropathologic criteria, we just heard them, though it's optional that we have in hippocampal sclerosis. And the TDP is subdivided into 3 stages with amygdala, then plus hippocampus, and then plus frontal. And it does not include any additional amount of pathology or something like that. So which means that one inclusion in the amygdala would account for late NC stage 1. So if we include, or if we use the late NC criteria, what we have, and if we look at how FTLD TDP and ALS TDP cases look like, and these are just heat maps of semi-quantitative scores of TDP pathology in some brain regions in FTD cases, and in these are clinically pure ALS cases. By definition, more or less all criteria, all cases, FTLD TDP, they fulfill criteria for late NC, and by definition, a significant number of ALS cases actually fulfill the neuropathological criteria for late NC. And I think this is pretty, I think we are, for most of the cases, we agree that this is not the late we are actually talking about. So I think some thoughts I would like to share with you. I think one possibility would actually to include some exclusion criteria in the current criteria. So I think one simple one would be that if there is typical ALS TDP pathology in the primary motor system, the term late NC should be avoided. The second exclusion criteria I want to bring up might be that we should incorporate our knowledge on the heterogeneity of the cortical TDP pathology with the distinct FTLD TDP types, which have been described, which I briefly mentioned from A, B, C, D, and E already. And we know actually already from the very early reports of concomitant TDP pathology in hippocampal sclerosis and Alzheimer cases, that the cortical pathology in what we now call late NC usually resembles the FTLD TDP type A, which is characterized by predominant upper cortical inclusions, and compact inclusions, fine dystrophic neurites. And this is already mentioned in the highlighted here in these early publications, 2007 and 8. Obviously, the idea of so how can we add additional information to these or use these types for neuropathological diagnostic, and the idea what is behind these types, or the molecular basis for these types, is in analogy of the prion concept, is that there are actually self-propagating conformers of an aggregated protein, which are the basis for these heterogeneity, and that a popular hypothesis which is postulated that in fact we have a heterogeneity in FTLD TDP due to the fact that the inclusions or the composition of the TDP aggregates are distinct on the conformational or biochemical level, and that these so-called types are then able to propagate in a prion-like manner, being associated with specific cellular tropism and prion-like replication effectivity. So, and one project we, and I think many other labs are working on, is to identify what is really the molecular basis, and one way to do that is to generate subtype-specific antibodies. And we recently, though in 2020, we published a study with a novel phosphorylation-specific TDP antibody, which is against 369, which showed a highly specific type-specific immunoreactivity, as shown here. So this is in red here in these immunofluorescent stainings. In red is the gold standard antibody 49410 TDP, and using these novel antibody, the pathology in ALS type B and type C cases are nicely co-labeled by these green staining here. But if we look at the type A pathology, this is not recognized by this antibody. So which means this would be, so first of all, it supports the hypothesis that there might be different conformers, and this might be a tool to use in the future also for difficult cases to diagnose. There are actually, to confirm that indeed the late NC pathology is type A, this is illustrated here. So these are unpublished data, but we looked at several cases now. The pathology here with the 49410 TDP antibody here nicely showing this type A pattern in a late NC case with high Alzheimer co-pathology, and as confirmation that indeed this seems to resemble type A pathology. It is not stained with this 369 antibody, and confirmed also by double labeling immunofluorescence. There are actually, so it's always difficult to, if your readout depends on that there is negativity. So though there are many other antibodies right now in the pipeline, and one very preliminary result here that we might also have antibodies which are actually type A, specific for the type A pathology, as shown here, this clone 15D2, which does not recognize the type B pathology. And I think there might be other antibodies to come, hopefully. So, which means that these would be exclusion criteria one can think about, and the type-specific antibodies might be useful in the future for difficult cases. So, which leaves us then still with the boundary issue of an diffuse late or late NC stage 3 to separate them from type A cases. And there are some, though this is highlighting one more recent paper which already tried to address that. So in general, I think there's the gut feeling from most neuropathologists that there is usually more in those we call FTLD TDP than in the others. And this is more or less what is shown here in this paper. But per se, moderate to severe versus mild to moderate in an individual case might be still problematic. And particularly also to judge what is moderate might be really depend on the experience. What are the usual cases you're looking at? So what is your grade of your personal scale of what is much and what is mild pathology? So I think the one thing what might be helpful is to integrate something like the ratio of frontal and temporal pathology, and perhaps also include other brain regions which are usually heavily affected in FTLD TDP cases. And there's not much literature on latency on other regions, so I think that might be something worth to continue. The last slide, I want to just highlight some questions I have as a neuropathologist with the concept on latency, late and clinical relevance. So, and I think this was, the terminology was also some cause of discussion when the names came out. So I think the concept implies that at least at a given severity, limbic-predominant age-related TDP pathology, so latency, is causal for functional impairment, which is an encephalopathy with a characteristic clinical phenotype, and this defines a clinical pathological entity. And I think we have to be careful, and I think we are all aware that association of limbic-predominant TDP pathology with a higher likelihood or severity of an amnestic syndrome does not necessarily mean a causal relationship. And in fact, we should not forget that it might be actually, we already heard that it's very complex, but it's also possible that actually the TDP pathology is actually influenced by many other factors which might be perhaps more relevant. I think we should just not forget that it might be more complex than what the terminology right now might suggest. And I think open questions from a neuropathological point of view is, I think what I would like to have is actually what are thresholds of latency pathology to be considered as clinically relevant when I report something. So is it one neurite in the amygdala? Most likely not. So I think this would be helpful. I'm also not that super happy with not including the hippocampal sclerosis at a more important part. So in particular, I would be interested if TDP with and without hippocampal sclerosis, whether these are actually similar or different processes, phenotypes. I think this is something which should be sorted out. Obviously, clinical features to predict latency, we already heard that. And I think all these interpretations, we also heard that really require the careful control for the common co-pathologies. And here are just some of them. I think there's agoraphilic brain disease, RTEC, and many other co-pathologies which need to be taken into account. And I think one last statement, I think with all these with some of these open questions, I think the current criteria, what we have for latency, might be a bit too simplified to address all these questions. I think at least in a scientific setting, we have to dig a bit more into detail in the distribution and amount of pathologies to address these questions. With that, I would like to thank you for your attention.
So much, Manuela. Those are fabulous points, and hopefully we'll have more discussion about those in our discussion. Our next speaker is my co-chair, Dr. Pete Nelson, who is going to be speaking on late, where we were, where we are, and where we are going.
Pete, you're muted.
You're on mute.
It never ends. It never ends.
The slides looked okay.
Okay. All right. So this is what I'm going to be talking about. So the first thing I'm going to do is present somebody else's data. But before I get to that, I'm just going to underscore that we need nomenclature that acknowledges that there's a divorce really between a lot of what we think of as pathological and clinical diagnoses. So the nomenclature is critical to have the late NC and the ADNC. These are concepts actually that I attribute to Tom Montine's ideas, but I think that we've all sort of accepted them. We're all here partly because we care about public health and the diseases that perturb it. The impact of a exposure or disease on public health is proportional to the morbidity and mortality for a given person affected by that and the prevalence in the population. Glad to say that there is a metric for that and an analytic process for coming up with that number. And it allows us to ask what percentage of dementia of the Alzheimer type in a population is attributable to late NC. Now, our colleagues at Rush University went to the trouble of doing this analysis, which I think is really important. And these numbers here give you an idea, taking all of the cognitive impairment and the diagnosis of dementia of the Alzheimer's type and the different pathologies. And these numbers add up to almost 100. So you can infer that approximately 15 to 20%, and this is what I want everybody to take away, of Alzheimer's disease type dementia risk that we know of is attributable to late NC. And the corollary, though, is that only around 40% of the assigned AD dementia risk is attributed to the plaque and tangle disease of Alzheimer's disease. That is one of the reasons why the clinical trials are failing, and some of the problems that Risa pointed to. And kudos to Julie Schneider and the Rush University team for this analysis. It's a very important point, 15 to 20%. So where were we before? In 2019, we did not discover a new disease. Scholarship had come out over decades about this, but there previously was no consensus-based effort to tackle TDP-43 pathology and aging, no common terminology. I had to sit and have our cases couldn't have diagnoses for over 30% of the autopsies, and the TDP-43 in aging was underappreciated and greatly understudied. Now, the concept of late is broadly accepted, but there are important questions, and Dr. Newman pointed out many of them. Some of the important questions relate to classifications, prevalence, early disease, and genetics. One of the things I hope that people will take away from this meeting is that a lot of these questions actually now have been addressed, and more of them are being addressed with real data in real time. So first, I'm going to talk a little bit about classification. What I want you to take away is that late is, in fact, a prevalent, distinctive condition associated with substantial cognitive impairment and with a recognizable set of genetic, clinical, epidemiologic, and pathological characteristics. It's really important, though, if you have this sort of a new kid on the block as a classification, how does it interact with and bump into and interrelate with other accepted clinical pathological disease entities such as FTLD, hippocampal sclerosis, and Alzheimer's disease. So the main points as a spoiler alert of this talk are going to be that the FTLD and late pathologies differ, and not only do they differ, but they differ specifically and significantly. Most of HS is a subset of late NC, and AD pathology, although they both are very common, they commonly occur together, they often also commonly occur without each other. And I'm going to show you data and or past papers that substantiate each of these. So in terms of past papers, we use data from two large autopsy cohorts, one clinic and one community-based, and developed criteria to distinguish confidently late from FTLD. As Dr. Newman pointed out, the explicit criteria, as you now read them in the 2019 paper, do not necessarily specify, but with these criteria, we could differentiate all late cases from all FTLD cases that were checked with 98% specificity in the cohort. And that is better than many other dementia pathologies. I would have to say it's also not just us, part of the YouTube compilation of PowerPoints that are associated with this meeting. Dr. Alexandra Young has a beautiful new study. They use fancier work and they look and compare the pathology between late, FTLD, and ALS, and they find 96% cross-validated accuracy. And let me tell you, folks, That is better than the different specificities for most synucleinopathies, most tauopathies, and most subtypes of FTLD. That ABCD thing, everybody acts like it's totally cut and dried. It's not cut and dried. 96% difference is a very big difference. So the big point is, I totally agree with Dr. Newman that we need to develop these exclusion criteria and make it more specific in our criteria. But the pathologies itself, the ground truth, they differ very much. What about HS? Most of HS in aging is a subset of late. This is something that was found, but one of the many findings by Dr. Dennis Dixon and the team at the Mayo Clinic, along with Dr. Dennis Dixon and Dr. Keith Josephs. This is a group of people that have made many great advances in the field, and I think that they deserve a lot of kudos for moving this field forward, and I presume that they'll keep doing so. This is some of the data. This is from both NAC and ROSMAP, two large autopsy cohorts depicting in Venn diagram form that are proportional to the actual numbers of late and HS and neither. Most of the cases had neither, but the cases that had late were more numerous than those with HS, and most of them were in here. The HS cases outside of the Venn diagram were maybe hypoxia or some other cause, because HS is caused by other things, but the data are compatible with a pathological sequence. This is actually from Adam Dugan and Dave Fardo's paper. He's going to talk more about that, and he's talked about the genetic underpinnings of it. But the pathological sequence is compatible with these data, where you go from having no late to having late with HS. And so what is up with that conversion between late and HS? Is it important? And this is one of the questions actually that Dr. Newman asked as well. And actually, Dr. Boyle pointed out that it's actually associated with additional cognitive impairment. And our findings agree with that. We did not find that there was any association between the presence of HS and Alzheimer's disease pathology, seizures, hypertension, or the other exposures, but it was indeed associated with worse cognition. This is a paper that's in press in neurology, a collaboration with our NAC friends. Catherine Guthrow is the first author, but the amount of HS was associated with higher late NC stages and with cerebrovascular pathology. So it does seem to be that they're integrating things going on. So putting aside classification for a second, let's talk a little bit about prevalence, because prevalence is an essential point. A key challenge is that to address questions of epidemiology, including prevalence, requires community and/or population-based studies. So now I'm going to present new data that I'm very excited about. It's a combined cohort with 13 different large community-based autopsy cohorts with a sample size over 6,200. Average age of death is rather old at 88, and about a quarter of the people were ApoE positive, which is representative of a broader community. These are not my data. These are the people that provided the data. These are the cohorts. They represent 13 cohorts from 5 different countries and 3 different continents. And you should see all these people's talks and or discussions. I think it's a very vibrant time in this field, and all these people contribute the data. And so what about late in this large data set? These are not my data. These are 6,200 people. 39.1% of people in this expanded meta cohort have late NC. That is a very large proportion. Now, around a third of these are stage 1, so they would probably, as Manuela Newman said, would be subclinical. So these are probably not clinically expressed. There's a stage 1 of every pathology I know of. Brock stage 1 is not associated with cognitive impairment. Thal phase 1 is not associated with cognitive impairment, and nor do I assess that late stage 1 is. So, but if you look at this number and say that 39% have it, 1/3 are late stage 1, then you go boop, 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 and so 25% of 88-year-olds have late NC stage greater than 1. That is robustly associated with cognitive impairment in many different studies in many different places. So it's around 25% of people have late NC of a severity that's associated with cognitive impairment. Some follow-up questions include, does late NC occur in the absence of either AD or FTD clinical syndrome? And does late NC tend to eventually progress to FTLD TDP? Now, these are sort of sometimes given as obtuse opinions, but I can tell you these are actually hypotheses that you can address in a scientific way, and let's get to that. So this is, again, that large combined cohort, I think, which is unprecedented, and I think will set the standard for these data. So this is the number of people we're talking about, over 6,000. The biggest group, as in any community-based cohort, is actually the people that lack Alzheimer's disease. There are no neuritic amyloid plaques. However, as you go up in severity, there are other ones. So what about these people with no neuritic amyloid plaques? This enables us to address this question. Is there late in the absence, and none of these people, as far as we know, had FTD. So is there or is there not late NC in these groups of individuals that lack Alzheimer's disease? And here's the answer. Yes, 27.1% of people in this group have late NC. So that is no longer a question. We have answered that question. If somebody comes up with 14 community-based cohorts and 6,400 people that are separate, which you can't because there are no more such autopsy cohorts and there are none, then you can say that. But at this point, this question has been addressed. Follow-up question, will those AD pathology negative, late pathology positive brains go on to develop FTD? This is a corollary of the more folksy question. If she had lived to age 125, she may have developed FTD or FTLD. Well, what's the context of that? The context of that is the human aging curve. This curve is our genetic destiny. The contours of it are affected by environment, but the endpoint so far is not. So these are Social Security Administration actuarial tables, the number of people alive at different ages of 100,000 starting point. So you can see that males die earlier, females die later, but they all eventually die. Around 40%, if you go to 88 years old, of 88-year-olds have any late, as we have seen. And so nobody is living to 125. It's just not our destiny. So that's a specious question. The real question then is, what about the people that get further along? If 40% of them up here, if 40% of them up here have late, what happens to these people down here? So we know that around 2% of people survive to the age of 100, and we can ask the question, what happens with them? And we did ask this question, Dr. Jana Neltner, and we came up with a large cohort of centenarians, over 70 of them, and we found that none of them manifested any FTD clinical syndrome or FTLD TDP pathology. It's not the natural history of late to become FTD in the vast majority of cases. So these addressable hypotheses have been scientifically queried, and we've come up with answers. Does late NC often occur in the absence of either AD or FTD? Yes, it does often happen. Does it eventually progress to FTLD? No, it does not. These are compatible with there being a somewhat coherent disease entity that is definable in the clinical and pathological spheres. So in terms of phenomenology, the AD-NC related factors certainly seem to promote late, because around 50% of people with moderate or severe cases of AD-NC have comorbid late. However, late often exists outside of AD-NC. Or as we have seen, 27% of AD-NC negative cases have late NC. Late NC related factors promote HS. Late NC is not, and I'll repeat it, not pre-FTLD, and it only rarely would be confused pathologically or clinically. TDP-43 pathology is a feature of late, but it's also present in many other conditions, along with these other promiscuous pathologies, tau, A-beta, alpha, synuclein. Those other conditions are just not late. They're just different conditions. So we've talked about a little bit about classification and prevalence, early disease and genetics. I don't have time to talk about, but I can heartily recommend the future talks later in the meeting in a couple hours by Dr. Sikowski, and about genetics by Dr. Fardo. They're going to be great talks. So where is the field going? There are three things I wanted to point out. What is most needed? The future of clinical trials and molecular mechanisms. And I do it very quickly. Clinical biomarker is what is most needed. It's been reiterated over and over again already at this meeting. And it is my hope, I'm looking here, there are 301 people here. I think that some of those 301 are going to actually achieve this amazing goal. What about the future of clinical trials? Well, this is sort of a tawdry echo of Dr. Sperling's chart with cognition on the y-axis and time over here. No pathology is associated with no decrement of cognition. However, pure late NC is associated with decreased cognition. Pure ADNC has a swifter course, and the combination has even worse. The kicker about this chart right here is that all of these are prevalent. Pure latency is about 10% of our community-based cohort. So it's a very common thing. But more prevalent is pure ADNC, and more prevalent still is ADNC plus late. This is the most common of these three options. So sometimes people say late is associated with the more gradual reduction, and that's sort of true. But in the most frequent scenario where you see late, which is ADNC, because most people have ADNC when they're 85 years old, more than 75% or so. In this context, it's a more swift and severe clinical course. If you don't believe me about either the prevalence or these cognitive trajectories, see the talk about Arian Abner, and actually Dr. Boyle did it wonderfully earlier. So what about the future of clinical trials? We're going to have a drug for late NC, maybe a separate one for pure ADNC. And this is something that Dr. Sperling touched on a little bit, that we may need something different, either a combination or a separate approach to do both. I encourage folks to check out the talks and the parallel PowerPoints on YouTube by Dr. Jacob, but I do also want to say this to remind me to point out that we at University of Kentucky are lucky to have the first, and as long as I know, only clinical trial ongoing recruiting individuals for late NC who screen failed the Alzheimer's trials. So what about molecular mechanisms? First, let me give a shout out to my colleague, Dr. Mylinda Selenica. She's giving a wonderful YouTube PowerPoint about a possible molecular mechanism for late. But in a broader scheme, I just encourage people to keep together the experimental systems and the human brain phenomenology. And one of the really important points of human brain phenomenology is prevalence. This is a 1 in 4 affecting disease. FTLD is a 1 in 1,000 affecting disease. That is quantumly different. It's a very different thing. So in conclusion, late is a very prevalent brain disease with recognizable pathology and other characteristic features. The epidemiology of late helps set it apart. Late is often in combination as a pathology with other common pathologies of human brain aging. And then I'm going to conclude with what I started with, which is not my data, which is Dr. Schneider's and others' data, but it's very compatible with our data. Late is associated with a substantial proportion, around 15 to 20%, of amnestic dementia burden in the aged population. With that, I'll say thank you. Thanks to my boss, Dr. Van Eldik, and the other collaborators and leaders of this field. Thanks to the NIH and NAC teams and the funders. Thanks to Gloria. Thank you, the research volunteers here at the University of Kentucky. And with that, I'll stop my sharing.
Thank you, Pete. That was awesome. And just a shout out to Patricia Boyle, because she's really led that work in attributable risk. Rather than me, my statistical skills aren't good enough for that. But anyway, yeah, let's move on. We're running a little bit late, but I think we built in enough time that if we do run over 3 o'clock, we probably could take a little bit shorter break if people don't mind. But let me introduce Dennis Dixon and Dirk Keane, who are neuropathologists, well recognized in the field. You've seen Dennis's name come up a lot today, and Dirk has done a lot of work with TDP-43, and they're going to be fielding the questions that are in the Q&A and directing them to the panelists. And if they have, and certainly we're certainly interested in any comments or questions that they may have also.
Thanks, Julie. I defer to Dennis to start this. If you're up for it, Dennis.
Well, one way, so I think it all depends on how you frame questions sometimes. So there's this concept of a straw man argument. And if you're arguing that late is FTD and an early stage of FTD that would progress because this is a degenerative, I would ask Pete, what about the idea that it's an incomplete form or a form first of a disease? This is well known throughout medicine that sometimes, for whatever reason, the disease doesn't manifest in its full extent, but it has the features of the full-blown disease, but it's truncated by some process.
So form fruits is
Perhaps
usually a
old
term
age.
used to describe when you have a commoner disease and the truncated form is rare. In this case, the common disease, which is a 1 in 3 disease, is extremely common. And the rare one is the one that you have this fulminant problem. So that's a totally different situation from a form fruit and what is generally used. If there's overlap, there is overlap. There's pleiotropy between Alzheimer's and Parkinson's. The big risk gene for Parkinsonism is tau. Go figure. There's pleiotropy. That does not mean that Parkinson's is Alzheimer's. It's just or a tauopathy. It just means there's pleiotropy. There's pleiotropy with a lot of things, but in fact, the genetic contributions to late are very different from FTLD, and they're very separable conditions on very many different levels.
So I'll just say one other thing, because I think that Dennis brings up a really good point, which is we know that there's amnestic frontal temporal lobar degenerations. We know that that can happen. And what is the intersection between an amnestic frontal temporal lobar degeneration syndrome and in late? So is it possible that there is a spectrum of disease with TDP-43? I mean, as I mentioned in my talk, there are some similarities. We see some similar risk factors. We see frontal and temporal predominance in this. There's certainly shared mechanisms, or seem to be shared mechanisms. And I'd be curious, Pete, or anybody else, what you have to say about that.
I presume there's shared mechanisms between CTE and Alzheimer's disease. There's shared mechanisms all over the place, but the question is whether or not you should have there be a CTE in Alzheimer's disease, because they help you in a certain clinical pathological context. Late is a useful context because I now can diagnose my patients without calling them FTD, because they go home with a 90-year-old with amnestic problem and they're not going to be Googling FTD, which has nothing to do with what they had.
So Pete, I don't want to take this too far, but here's another analogy. Amygdala Lewy bodies are pretty common in aging. They often occur in the setting of advanced AD. And yet we recognize there's a whole range of Lewy body disorders, ranging from brainstem predominant to a limbic and neocortical. We don't consider them different disease processes. They're all part of synucleinopathies, but they have different distribution and different severity. How is TDP pathology that's limited to limbic structures, especially the amygdala, any different conceptually from amygdala predominant Lewy bodies?
So the question is, as far as we know, there may be people who stop having TDP and it stops in their amygdala. We don't know if that's true or not. There's a subset that have it, and it seems to be mostly subclinical, and we call that stage 1. There is also people that are Brock stage 1. They could have part or late, and we don't know. We just call it Brock stage 1 as an Alzheimer-like thing. And so I think one of the key things that I hope will come from this meeting is that we could tweak our diagnostic criteria, because I think we should. But there clearly is a condition with TDP proteinopathy that seems to grow from the amygdala to the hippo to the middle frontal, and that is not just impactful, but extremely impactful, and not just common, but extremely common, and it's hugely underappreciated. And in the past several years, there's been an uptick of scholarships because we brought attention to it, and I'm glad that we did.
So we could talk about the FTLD late questions for a long time, but there's a lot of questions in the Q&A, and there's been a lot of questions in the chat. So and for the panelists, there's a lot of questions in the Q&A directed specifically to a very specific question. We can answer those online. And so I'm going to try to go to some questions that maybe are more broadly applicable for the group, and I'm not going in any order. So I apologize if your question was first or whatever, but maybe this from Dennis Smirnov. Since late and AD tau pathology often co-occur and seem to have combinatorial effects on cognition, do these pathologic changes affect distinct or overlapping neuronal populations within the MLT or elsewhere? does it appear that one pathology increases the prevalence or severity of the other? And I don't know who might be good to try that. Maybe Julie to start?
I was gonna ask Manuela.
Oh, that's good.
Yeah, if she wanted to address that.
Honestly, not sure if I want to address it. What was the question?
It's in the Q&A from Dennis Smirnov. It's since late and AD tau pathology often co-occur and seem to have combinatorial effects on cognition, do these pathologic changes affect distinct or overlapping neuronal populations within the MLT or elsewhere? Does it appear that one pathology increases the prevalence severity of the other? So it's really the big question about, do these pathologic peptides interact, or is this summative, and are there overlapping cellular or neuroanatomical sort of regions or vulnerabilities to these different pathologies?
So for sure, the hippocampus amygdala is something which is heavily affected in Alzheimer, and it's heavily affected it's the region for later, but it still doesn't, though at least in my experience, no. Let's say if you have a hippocampus which is full, or the amygdala which is full with tau pathology, you will find inclusions which are in the same cell. But per se, there is, I think, not much evidence that there's a direct co-aggregation of TDP and tau. But obviously, there are regions which most likely are more vulnerable for whatever these lysosomal dysfunction or whatever you can come up with, proteasomal dysfunctions, which are more prone to result in protein in aggregates. I think that's the best what I can address to that right now. Maybe someone else want to.
Yeah, and as sort of a related question from Gil Rabinovici, is the overlap of TDP43 and tau within let me get it right. Regarding possible shared mechanisms, can someone comment on the co-localization of neurofibrillary tangles in TDP43 lesions? And does quantitative IHC suggest the burden of tau and TDP43 lesions are correlated? We may have some talks today.
So yeah, there's going to be a number of people that are going to talk about stuff related to that in the afternoon. The one point I would make is that there clearly is both directions. So people that have Alzheimer's disease tend to have TDP within tangles in the areas early affected in Alzheimer's disease, like the entorhinal cortex, in actual tangles. However, in addition to that, people that have late but almost no Alzheimer's disease, but have late type of TDP inclusions in the dentate granule cells, have tauopathy in those TDP inclusions that tend to be there. So that is strong evidence that there is synergistic intracellular influences where one is present physically in the same cell as the other, highly disproportionate. So Dietmar Thal has a really nice recent paper. Dennis Dixon and Keith Josephs had a really good paper about NFT type, beta type of pathology coexisting. And we did one from our center that showed that there was a statistically strong tendency for the co-localizations in the dentate granules of cells way above the supposed Brock staging to have tau tangles in the TDP43 bearing cells of the dentate granule cells.
Dr. Sperling, you have your hand up?
I do. Sorry, I have a follow-up question to that. So we right now are grouping AD pathology, probably appropriately so, as amyloid and tau. But I'm actually interested in the group who has high amyloid. How often is it that you see amyloid and TDP43 without much tau, or vice versa? And how does age figure into that? Because we see this interesting thing that younger participants who are amyloid positive have more tau than older participants who are amyloid positive. So is there some reason that having amyloid changes the likelihood that you have tau versus TDP43, or do you almost always see them overlapping, as you were saying, Pete?
Dennis, you have thoughts on that?
Well, I think the amyloid only pathology, which I think of as pathological aging. I don't know if you like that term or not, but it can actually occur in a combination with a variety of things. It's an independent process that occurs with Lewy bodies, with TDP pathology, and maybe limited tangles. So I think you can divorce them, and I think molecular imaging is starting to show this. I'd be interested in your thoughts. The possibility that you could see a relatively pure amyloidosis of the brain, which I would call pathological aging, that has minimal tau, minimal TDP, minimal synuclein, and then you can see varying degrees of combinations of all three of those major proteinopathies with A beta.
So yes, I agree. We definitely see that, although I think it depends on what we call, again, pathologic aging, because many of these people have elevated amyloid, also have tau in the rhinal cortex, entorhinal cortex, and that does look quite relevant for whether they decline. And maybe we don't call them Alzheimer's disease, but they're in trouble. And of course, we can't see with biomarkers the TDP-43. So I'm trying to understand again whether if we see amyloid and someone's declining and they have a little bit of, let's say, entorhinal tau, is it also likely they've got TDP-43, or does that really depend on whether they're less than 65 or older than 65?
I think maybe I'll also take that, is I think that, yes, it's going to depend on age. But remember what's happening with pathologic studies is it's really cross-sectional. So everything we have is when a person died, and people with bad Alzheimer's disease tend to die younger. So we tend to see these older people who have less AD pathology, who have less tangles in their brain, and they're the ones developing the TDP. So is there a direct relationship between the TDP and the tangles, or are the people with the tangles dying, and then we're just seeing the people with the TDP? I don't know that pathology necessarily can answer that question, but certainly it does. If you have the tangles in your mesial temporal lobe, you have a higher likelihood of having TDP because AD gives you a higher likelihood. But beyond that, I'm just not sure what we can say. And then you get into what's driving the process of cognitive decline, right? And probably both are driving the process of cognitive decline, not just TDP, not just tangles. I saw in the chat someone asked about, how about people with no amyloid or no tangles? Well, we can't find very many people with no tangles. Unlike the tau staining, I think, and not tau staining, tau PET, where you can get, quote, no tangles. In a pathologic specimen, we probably have at the most 20 people in our 1,700 that have no tangles anywhere. So they're extremely, extremely common. Amyloid's a little bit easier to answer. And, where we have more like 80% of our older people having some amyloid. So we could certainly look at that data. How many people without any amyloid have TDP?
So just to follow up, I think this highlights two areas of need for the field. One is quantitating the path, different quantitative approaches to assess the pathology. But the bottom line with neuropathology in people is we can only look at one time point until we have really sensitive and specific biomarkers. And so the experimental models that are developed for these different disorders and that will continue to be developed, whether they're cells or mice or whatever, are really critical to understanding the biological mechanisms and the relationships across time for these different pathways. And so I think we haven't talked much about that, but that's obviously going to be critical for us to really find the final answers. If I could just take for Dr. Peterson, there are a couple questions about scans, maybe Dr. Sperling, but I think Dr. Peterson, I have a question from Andrew Budson. Can prominent parietal atrophy distinguish between predominantly AD, so positive parietal atrophy, versus predominantly late pathology, which would be negative parietal atrophy? I don't know if, and then just from an extension to that, how sensitive and specific is the medial temporal lobe atrophy for late, do we think, with respect to what we have now for biomarkers, which is essentially our structural scans?
Yeah, good good questions, Dirk. I mean, I don't think that the medial temporal lobe measures are all that absolutely specific, but I think they're pretty good. I think what, and I'm not sure if Andrew meant atrophy in the parietal region or if he meant hypometabolism in the parietal region. I think the PET scans, the FDG PET scans, are actually pretty good at differentiating the Alzheimer's disease pattern from perhaps a late pattern. So I think that there's more information in the FDG than we had previously gleaned. I think less so with MR and atrophy patterns.
Great. Dennis, any questions that you'd like to?
I think we've fielded most of the questions. No?
There are some very specifically to certain people. Dr. Boyle, you've got quite a few in there, and so we can answer those online. I don't know when we have to cut off, but there is a new question that I think is interesting and focused on therapeutics, which we haven't really talked about very much, from Dr. Selenica. As the therapeutic efforts are focused to target early in the disease, how would one frame the therapeutic efforts for late neuropathologic change, especially considering late age feature of the disease, but also the regional pathology? So I don't know, does anybody want to, Dr. Sperling, anybody want to try to take that on? How do we?
Yeah, so I do think we have to target TDP-43 early also. I think all of these, that by the time we're seeing a lot of this, that you can see pathologically or we can see with biomarkers, there's a lot of neuronal dysfunction and death. So unfortunately, as I was saying in my talk, I don't know that we have a specific therapeutic for TDP-43, but given what we just were talking about, this overlap of tau and TDP-43, alpha-synuclein, A-beta, and all of these being, proteins that are not handled well and misfold, and also that all have these oligomeric forms. And then, so I do think that trying to go after something that would be more ubiquitously helping us with multiple protein handling might be a way to also go after TDP-43 if we had those mechanisms. But again, if you get us a good biomarker for TDP-43, that'll help us develop therapeutics that might be more specific to it.
Yeah, thank you. Biomarkers. That's where we really need to go for this field, I think, to make a lot of progress. I'm going to take a little bit of discussion leader license, and Dr. Newman had raised a couple questions in her talk that I thought were really interesting, and I'll highlight a couple of them. Dr. Newman, I don't know if other panelists would like to take some of these on, but I think there's a really important question about whether hippocampal sclerosis if you have hippocampal sclerosis or not, is that similar or different? And then I think the interesting question is, what is a threshold for something to be clinically relevant? I think for late, we are, for the consensus, the idea is if you have stage 2 or 3, that's clinically significant or clinically relevant. But I'm curious if any of the panelists, I don't know, maybe Julie, want to comment on hippocampal sclerosis and how we refine our late criteria. Or maybe someone else. Sorry, Julie.
No, that's okay. That's okay. No, I agree with you. I think, it's pretty clear, at least from the study so far, that it's really stage 2 and 3 that are driving cognitive impairment, amnestic disorder. We really have not seen anything with amygdala. Granted, we don't have a lot of behavioral measures in ROS-MAP, and could there be something going on in the amygdala? I think Pete's written a paper about all the prodonopathies occurring in the amygdala. We see the amygdala as a hotbed of amyloid and tau and alpha-synuclein, and it has a lot of stuff. It's hard to believe that's not causing problems with people's some sorts of behaviors, because the amygdala is prominent in behavior, but it's not something that we're detecting right now well, and we've looked a little bit at that. As far as hippocampal sclerosis, I think a lot, there just needs to be a lot more done. Why is it that some people develop it? Why is it that some don't with TDP-43? It's segmental, as Pete has reported. We're seeing that too. If you don't look in multiple places, you may not see it. What people don't realize is that, us neuropathologists are not always in tune on what we call hippocampal sclerosis, and that you have to have a threshold. It's kind of like MCI versus dementia for clinicians to think about. You have to have severe neuronal loss and gliosis. What is severe? And when do you draw that line? When is it not severe enough that you don't call it hippocampal sclerosis? So, these are all issues that we recognize in the neuropathology world. And I think there's other factors such as, genetic factors, who goes on to get hippocampal sclerosis. Is everybody inevitably with TDP-43, if they live long enough, going to get hippocampal sclerosis? I think that's a very difficult question to answer. Pete?
So I would say I agree with Dr. Newman, but you just said that HS is important. It clearly is important. Your data just showed it's important. Dr. Boyle showed that it's important, and it's clearly something that's associated with cognitive everything. I think that it's a little bit, when you have a group of people that are doing something different, sometimes you can't come to consensus about something. I would say that in the Alzheimer's disease one back in 2012, it was about the neuritic amyloid plaque. We could not come up with a consensus of what it is, even though it's the pathognomonic feature of Alzheimer's disease. In that whole consensus paper, a neuritic amyloid plaque is not defined. Same thing with HS in the consensus paper in 2019. We did not define HS because everybody does it differently. So we want to be the gold standard, but we are not standard. We think about our goldness, but we don't think about our standardness. And Manuel, you do HS different than I do. I do it different from Dennis. Dennis does it different from Julie. You may like that, you may not like it, and you say he's right, she's wrong. But the bottom line is we all do it differently. So we cannot have, until we come up with a consensus for what it is and what it isn't, we can't just go calling it willy-nilly this and that, because I promise you it's different.
I'll just argue that that's the case for a lot of the things that we do.
Yeah, that which is fine.
And that there's not, there's
fine. It's just when you look behind the curtain, there's a little neuropathologist messing
right.
up something.
So there's those in-between areas clinically, neuropathologically, where people are straddling the border and you have to make a decision.
But the bottom line is that the TDP-protonopathy is much more sensitive and specific indicator of the disease, that if there is not there and there is HS there, which occasionally happens, it's not the same one anyway. So you can't go with it.
Right. I think the other thing to point out is Keith Joseph's work at Mayo with, that people with TDP-43 have a progressively shrinking hippocampal sclerosis. Hippocampal atrophy. So it's continuing to decrease in size. At some point, it's severe. And when do we call it severe? When do we call it hippocampal sclerosis is what you're saying. And I think the same thing's going to apply radiographically. So when does imagers, when is it going to be enough to say this is hippocampal sclerosis? And that'll be super interesting to see if we could get a biomarker in that regard.
Oh, well, we are almost 10 minutes past. Dennis, you've been doing this for longer than anybody. Last words?
No, I like some of the thoughts that are raised by some of the people that in the chat and in the question and answer about the possibility of getting biomarkers. So, and people can look up the role of, for example, truncated Stathman-2 and how it's being used as a biomarker for ALS. Because it's a indirect effect of the TDP pathology in neurons. But nevertheless, we need to think outside of the box and maybe think about biomarkers that aren't actually measuring TDP, but something that's a marker that's a consequence of the TDP pathology. I like the question by Chris, but I don't know if we have time or if anybody has any information to actually address it.
So maybe we'll take that as the last. Does anybody have anything they can say about Stathman-2? The question is, Stathman-2 is being used as a potential biomarker for TDP-43 dysfunction in ALS. Is this possible for late as well?
People have to go home and do their homework.
Yeah, I can't answer that. How about Dirk or Pete?
I got nothing.
Yeah,
Right.
I don't think we know the answer, but I think that a lot of us are going to go back and look in, PubMed and start thinking about it. Anyway,
I would reiterate that there is a really interesting, some talks that relate directly to the questions here in the afternoon session very directly and are very, very interesting. And I highly encourage folks to check it out.
And one last thing, I'll just end here, is this really speaks to this intersection that even if you call these things different, even if late is different from FTLD, most of the work on TDP-43 has been in FTLD and ALS. And we really need to pay attention to that because there's worthwhile things being done that are likely to intersect as far as therapeutics and mechanisms.
Sure.
Okay, so anyway, this was a great morning or afternoon, depending on where you are. We only have around 17 minutes for our break. Hopefully that'll be enough for people to grab a bar of something or make their soup. And then we'll restart and do our lightning round presentations at 3:30 Eastern time. You can leave your videos. You can just shut off your video and mute yourself and then come back on in 17 minutes. Thank you, everybody.
Those of you who are panelists in this session, you're going to be moved out as panelists. So if you want